All right, we're going to go ahead and forge on. Part 2 of endocrine emergencies. Very exciting stuff, I know. It's not joint dislocations or anything like that, but come on, SIADH, right? Yeah, pretty painful, I know. So listen, I'll tell you, when I was first learning this stuff for this talk, this is the section that I always had the hardest time on for some reason, which was SIADH and diabetes insipidus. No matter how many times I learned it, I forgot it. I couldn't keep it in my head for some reason. So I finally, at least for me, I figured out a couple ways to try to remember it. So I'll tell you the way it works for me. Hopefully it'll work for all of you and it'll stick, all right? You may know it anyway, but in case, here's another way to think about it. So SIADH, let's talk about this and then diabetes insipidus. So ADH, anti-diuretic hormone. Let's do some basic things here. If there's such thing as diuretic hormone, it would make you pee, right? So anti-diuretic hormone would make you anti-pee, okay? So it's an anti-diuretic. It makes you hold on to fluids. That's the first thing to remember about this. That's what anti-diuretic hormone does, is it makes you hold on to fluids. It's secreted by the posterior pituitary. It squirts out the stuff. And when does it do it? Well, when you're dry, when you're fluid down, when you need a little volume, you're a little dry, your posterior pituitary secretes an anti-diuretic so that you hold on to fluids, okay? That makes sense, and that's normal physiology. The other part of normal physiology I want to tell you about before we get on to this disorder is to remind you that your blood and your urine usually reflect each other, right? They're in the same state, right? Because the kidney is just a big filter, right? Usually your blood and your urine look like each other. So for example, if you are really dry, you're concentrated, your sodium's 150, you're dry like crazy, what is your urine going to look like? Bright yellow, dark, that sort of stuff, right? Concentrated. Your blood's concentrated, your urine's going to be concentrated. On the other hand, let's say you're really well hydrated. You've been drinking tons of water, drinking lots of water, right? What's your urine look like? Looks clear, looks like water, right? So the normal state in the body is that the blood and the urine look like each other, okay? So if you remember those two things about ADH and about that they normally look like each other, now let's get into the disorder SIADH, and you'll understand it, I think. So SIADH is a syndrome of inappropriate secretion of ADH. You're over-making the anti-diuretic hormone for some reason. And think about what's going to happen. If you make too much of an anti-diuretic, you're going to hold on to too much fluid. And you're going to start to dilute out your serum sodium, right? So your fluid in your serum is very dilute. You're holding on to that fluid because you have an anti-diuretic and your serum sodium is low. Now again, in a normal state, when you're really dilute in your serum, your urine would look dilute. But in this state, it's the opposite. It looks really, really dry. Because what's happening is the ADH is telling the kidney, pull all the fluid into the blood, but don't put it into the urine, okay? It's messed things up, all right? So now you've got a dilute urine, a low serum sodium, and a dilute urine, sorry, I messed up. You have a dilute serum, sorry about that, folks, dilute serum with a low serum sodium because you're holding on to fluids, but then you look at your urine and it's very concentrated, right? So anti-diuretic, hold on to too much fluid, dilute out your serum sodium, dilute blood, but you look at your urine and it's concentrated. It shouldn't be doing that, right? That's SIADH. So whenever you see low sodium but a very concentrated urine, that's SIADH. When you've made that diagnosis, you need to look 3 places for the cause: the brain, the lungs, and the med list. And the answer is going to be there somewhere probably. Almost anything in the brain can do it: tumors, stroke, bleeds, whatever. Things in the lungs can do it: pneumonia, PEs, cocci, things like that can do it, right? And there's a whole bunch of things on the med list that can cause it. You're never going to memorize them all. You're going to have to look them up, okay? But there's lots of things that can do it. So you get a low sodium with a dilute serum. You look at the urine and it's too dry. You say that does not make sense. They look opposite of each other. That's SIADH. Look at the brain, look at the lungs, and look at the urine, okay? Hopefully that makes a little more sense now, okay? Think about the anti-diuretic. Think that they're supposed to look like each other and they don't now. So that's SIADH. Diabetes insipidus is the exact opposite. With diabetes insipidus, you lack the anti-diuretic hormone. Okay, you lack the anti-diuretic hormone or its effect. It's not working, okay? So if you lack an anti-diuretic, that's a double negative, that's the same as having a diuretic. So with this, you're actually going to pee like crazy. So here, with diabetes insipidus, and it's kind of like diabetes, right? You're going to be peeing like crazy, and you're peeing out, your urine gets very, very, very dilute. Now you've got a dilute urine, but your serum is very, very concentrated because you've dumped all that fluid out to the urine, okay? So again, your serum and urine are looking the opposite of each other. Something's messed up. Dilute urine, but a concentrated serum, right? So you're hypernatremic, but a very dilute urine. That's diabetes insipidus. And that can happen in generally one of two ways. One is that you don't make the antidiuretic hormone. Something has messed up your posterior pituitary. You've had a stroke, you've had a bleed, you've had trauma, something that has messed up your posterior pituitary. You guys have seen this before. Someone comes in a motorcycle collision, GCS of 3, right? You intubate them, you do all that stuff. You put the Foley in, and it looks like water. That's because that patient already has a diabetes insipidus. They messed up their pituitary. They don't have any antidiuretic, so they have diuretic. And they basically have a watery urine, okay, and a dry serum. All right? So that's the one way it can happen, is it messes it up centrally. You don't make the antidiuretic hormone. Or it could be that you're making plenty of it, but your kidneys aren't responding. Your kidneys aren't responding. That's called nephrogenic diabetes insipidus. So there's central diabetes insipidus, not making the ADH, and there's nephrogenic, where you're making the ADH, but the kidneys aren't responding. Does that make sense? Okay, so that's the difference between central and nephrogenic diabetes insipidus. And again, in diabetes insipidus, dilute urine, so watery urine, but they're hypernatremic. So dry serum, dilute urine. They're opposite of each other. Diabetes insipidus. How do you tell them apart? How do you tell whether it's central or nephrogenic? Well, you give them ADH. You give them the desmopressin, the DDAVP, the antidiuretic hormone. It's all the same words of the same thing, the vasopressin. You give that to them, and you see what happens. If you give them some ADH and things get better, then it was central. They didn't have enough ADH, and you just gave it to them and you fixed it. But if you give them the ADH and it doesn't get better, it wasn't central, it was nephrogenic, because they had plenty of ADH. Giving them more didn't help. It's just that the kidneys weren't going to work no matter what you did. Does that make sense? Okay, so hopefully now you'll remember SIADH and diabetes insipidus. Just remember the antidiuretic hormone makes you anti-P. Remember that in normal states, the urine and the serum look like each other. And in these states, they look opposite from each other because the ADH is out of whack. And you'll get all those questions right. All right? So that's that one. Pheochromocytoma. If you remember, this is a tumor in the adrenal medulla. Remember the adrenal medulla that makes the epinephrine and the norepinephrine and things like that? So it's a tumor in your adrenal medulla that's squirting out this stuff. And these patients can present with hypertension, and it's actually a treatable cause of hypertension. That is reversible, right? If you get rid of the tumor, their hypertension's gone. And if you remember, what happens with this is the adrenal medulla starts to have these spells where basically every once in a while it squirts out this norepinephrine, right? So you get these spells with the 5 Ps. So imagine that you got a norepinephrine, like a Levophed drip in somebody, and you're opening it up and then you're closing it. And you're opening it up and you're closing it. Well, you're opening it in these spells, and the Levophed gets out into the bloodstream, and they get the 5 Ps. So they get pressure, elevated blood pressure, pain, headache, chest pain, hurts all over, basically, right? Not good stuff. Perspiration, sweatiness, and pallor, right? Palpitations, I should say. So pressure, pain, perspiration because of the sweatiness, and palpitations, which is the fast heart rate. All the things that happen for norepinephrine, like a Levophed drip. So they get these spells. Just imagine them, the opening and closing the drip. That's a pheo. Pretty simple. Carcinoid syndrome is a good one to know. Not that we see it that often. We can see it, but not that often. But it's a real good destabilizing, test question when they talk about carcinoid, because you're thinking, what is this thing again? Again, this is really simple. Someone's got a GI tumor somewhere along the GI tract, usually with some mets to the liver, okay? And now this tumor, same thing, has spells where it secretes stuff. But now it's secreting prostaglandin and serotonin. And again, on and off, prostaglandin and serotonin going into the bloodstream. So these patients present with what's highlighted there: flushed skin, loose watery stools, and wheezing, bronchoconstriction, okay? So they give you a patient who's got, history of cancer, GI cancer, and now they're flushed and wheezing and, watery stools and things like that. That's carcinoid syndrome, okay? That's carcinoid syndrome, usually with mets to the liver. Treatment for this is octreotide, and then they can also do like resection or embolization of the liver where the mets are, things like that, all right? So we talked about a pheo where it squirts out norepinephrine. We talked about carcinoid where it squirts out serotonin and prostaglandins that both give you these spells. All right? So we've done the hormones now. We're done with all the hormones. We got a little bit of electrolytes to do. Sodium, potassium, calcium, mag-phos. All right? And then we'll do a little acid base and we'll be totally done with endocrine emergencies. All right? So let's move through it. Hyponatremia is a low serum sodium. You guys know about this. Again, remember that it depends on how low the number is and how quickly you got there. You know that as you get below 120, that's where it gets the most dangerous. But you have seen patients walk into the ED with a sodium of 116, perfectly lucid, giving you a great history, totally normal. And that means they got there over a long period of time. Otherwise, they'd be dead. If that had happened in a day, they'd be dead. This happened over a long period of time, okay? And again, like we talk about with everything, when you're going to fix these things, do it slowly. Symptoms of hyponatremia, nausea, headache, and then you can start to get lethargic and seizures. So it's neurologic symptoms. The brain does not like sodium problems. The heart does not like potassium problems, right? If there's a problem with the sodium, you're going to get neurologic stuff. If there's a problem with the potassium, you're going to get cardiac stuff. That's kind of mostly the way it works. Now, I know this looks very internal medicine-y, and I apologize, but when you get somebody with hyponatremia, one of the first things to do, at least I think that helps, is just to figure out their volume status. Are they too wet? Are they too dry? Or are they just right, like Goldilocks, right? Too wet, too dry, or just right. And let's think about this. How does this work? So, for example, hypovolemic hyponatremia. This is somebody who's dry and has lost sodium. So they lost sodium and they lost water. How do you get that? GI, renal, sweating, things like that. So GI, vomiting, diarrhea, renal, diuretics, things like that. All those sorts of things will do it, right? So they're dry, they lost sodium, they lost water. How about the ones that are too wet? These are all the big puffy states. So this is like heart failure, renal failure, nephrotic syndrome, liver failure, fluid overload. Think of it that way. A simple way to remember it is that they're so volume overload that they kind of dilute out their serum sodium. It's not 100% accurate, but it'll help you at least remember it, okay? They're big puffy states with a low serum sodium. And then there's the euvolemic ones. This is all the, their volume's normal. These are all the weird ones. SIADH, hypothyroidism, psychogenic polydipsia, where people just drink a lot of free water, things like that. Their total volume is normal, but their serum sodium is low. So you look at the person, are they too wet, are they too dry, or are they just right? We already talked about this. As the sugar goes up, your sodium goes down. We're not going to do that one again. There's some fake outs on sodium. Turns out that if you have a bunch of fat or a bunch of protein sitting in your blood, like a bunch of cheeseburgers in your blood, and you send that off to the lab, the machine is going to mess it up and measure it as a low serum sodium. It's not real. It's totally artifactual, but it's weird. So when you get a blood from the lab, it says their serum sodium is 110, and they're alive, you're like, what's going on with that? And so you ask them, you say, is the blood lipemic or anything like that? Is there a bunch of fat in there? And I guess the way I think about it is, when you send blood in the vial to the machine knows you're sending it, let's say, a 5 cc vial of blood, and it says, okay, the denominator is 5 cc's, and the numerator is all the little sodium particles that it measures. So it says, okay, I got a bunch of sodium particles in 5 cc's, that gives me 140, all right? But then imagine if that same 5 cc tube had, part of it was filled with cheeseburger, okay, instead, filled with fat. You're actually delivering less blood to the machine, because some of it's fat. So there's less sodium particles in that. And the machine says, well, there's still 5 cc's. It doesn't know. It's got 5 cc tube, but I got less sodium particles, so it thinks that you have a hyponatremia. It thinks it reports out a low sodium number, all right? It's a fake out. It's not real. So if you see that, to ask the lab to say, was the blood lipemic? Same thing if there's just a bunch of protein in there. Anything taking up volume can do it, all right? So that's a fake hyponatremia. Treating hyponatremia depends on how chronic, depends on how low, depends on the state, the volume state, okay? Hyponatremia should be corrected slowly. In general, you don't want to bring the patient's sodium up more than maybe a half to maybe 1 milliequivalent per hour, right? So if you're at 120, I don't want to get to 140 until anywhere between 20 and 40 hours, okay? A long time, not an hour, not 2 hours. Bad things will happen. You want to bring them up slowly when it's chronic, which it usually is, and you got to assume it is, okay? Okay, how do we do it? If they're too dry, if they're dry in front of you, that means they've lost sodium, they've lost fluid. That's easy. That's called normal saline. It's sodium and fluid put together, right? So sodium and fluid. So we just give them some normal saline. That's pretty simple. If they are hypervolemic, they're too wet, well, fluid's the problem. So here we got to fluid restrict them and give them some diuretics to get rid of the fluid, okay? Fluid's a problem. And if they're just right, if they're euvolemic with the weird diseases, you do the weird thing, which is you just free water restrict them. Most of those will correct with just free water restriction. Sometimes you can add a little diuretic if you want to speed it up, but basically just remember free water restriction for the euvolemic ones. So it's pretty simple. Are they too dry? Are they too wet? Are they just right? If they're too dry, you give them saline. If they're too wet, you restrict them and give them some diuretic. And if they're just right, you just free water restrict them most of the time. Okay. What about hypertonic saline? I haven't talked about that yet. When do we use that? So you're using hypertonic saline when somebody's in the real danger zone. Their serum sodium's got to be below 120, and particularly if they're having symptoms of it, like they're altered, they're seizing, things like that. That's when you want to bring out the hypertonic saline, because that's going to bring it up fast, right? And I just told you don't want to bring it up fast, unless like the risk-benefit thing tells you need to do it. So if the patient's really sick with the low sodium, pull out the hypertonic saline, start getting them up, they stop seizing, they get to 120, you take the hypertonic saline and throw it away and switch back over to normal saline. So hypertonic saline is for severe hyponatremia, particularly when they are really sick, like altered or seizing is when you want to pull that up. If you correct hyponatremia too quickly, you get this thing called central pontine myelinolysis. Myelinolysis, you're like lysing the axons and things like that, or the myelin of your neurons in the central pons. That is not good. That's a bad thing, okay? It's a bad thing to have happen to you. So you always correct hyponatremia slowly. Or hypernatremia. Remember, hypernatremia, you fix it too fast, you get cerebral edema. Hyponatremia too fast, you get central pontine myelinolysis. And the way I remember that, very simple way to remember it, is that hyponatremia has the word pon in it. Okay? And if you fix it too quickly, you get central pontine myelinolysis. Okay? And then hypernatremic's the opposite one. All right? Pretty simple. So hyponatremia, central pontine myelinolysis if you fix it too fast. Okay. And again, bad things. We talked about that. All right, so that's low sodium. Let's do high sodium. It's almost always because you're just very, very dehydrated, not because you've eaten a pile of salt, okay? Very, very dehydrated. And we have a strong thirst drive, so it's hard to get hypernatremic. Any of us sitting here, we start to get a little hypernatremic, we're going to go for the water, okay? But if you're elderly or debilitated, poor access to water, things like that, that's when you can get hypernatremic, okay? This is a formula that you can calculate somebody's volume deficit, okay, by looking at their sodium. And, obviously the higher their sodium, the more their volume deficit is. I'm not going to go through it. If you want to look at it, you can. I don't think they'd probably make you calculate it on the boards, but just in case, we've put it in here. If you plug in the numbers, you would see, for example, a serum sodium of 150 turns out to be about a 3-liter volume deficit for somebody, okay? And again, you want to give that stuff slowly, all right? Bring it up slowly. So that's sodium. Pretty simple stuff. Again, you've seen this all the time. Let's do potassium. Hypokalemia, very, very common. You probably see it every shift in the emergency department. If you remember, the EKG changes of hypokalemia start off pretty subtle, right? You get some flattened T waves. Maybe you get a U wave, which is like an extra wave after the T wave, right? Things like that. And then you start to get ventricular dysrhythmia. So you don't see much until you start seeing the stuff that scares you, right? The ventricular dysrhythmia. So that's a problem with hypokalemia. Pretty mild EKG changes until they start getting the badness, okay? By the way, particularly bad when patients are on digoxin. They're very sensitive to hypokalemia. So patients that are on dig, if their K is low and you're thinking about correcting it, definitely correct it if they're on dig. You don't want them in the low range. Bad things happen. How do you get a low potassium? Okay, being NPO or things like that where you don't take enough in, but usually it's increased output, right? You're peeing it out, or you're vomiting it out, or diarrheaing it out, or things like that. Those are the main things that'll do it. Other things that can do it. Anything that gives you an alkalosis can cause hypokalemia, right? So if you have an alkalosis in your blood from whatever reason, your blood wants to fix it. It says, I want some hydrogen ion somewhere. So it's going to start to pull hydrogen ion to fix it out of the tissues. When it pulls hydrogen ion out of the tissues, it trades with potassium. Hydrogen out, potassium in. So it starts to shift potassium into your cells. So any alkalosis will cause hypokalemia as well because of shifting it as well. All right? Treating hypokalemia, pretty simple. You want to replace it. And of course, what's better, PO or IV? PO, absolutely. PO, you can give larger volumes, you can give it faster and safer, giving it PO. So as long as the person has a working GI tract, isn't vomiting like crazy and you can't control it, then oral is definitely the way to go. If you want to add some IV, by all means, go ahead. but don't forget the PO route. You got this great way to get people potassium orally. When you give it IV, you can't put any more than 40 milliequivalents in a liter, and you can't run that any faster than over an hour, okay, than that liter over an hour, 40 milliequivalents an hour. And I promise you that when you write that order, your nurse will come find you, okay? Your nurse will come find you and say, doctor, you can't put that much in the bag, and then we pull out the protocol and the books, and they're looking at the stuff, that sort of stuff, because they don't like that concentrated. That's the most you can use, and usually your nurse isn't going to let you do it anyway, okay? So oral is the way to go if you can do it. Oral rather than IV. Add IV if you want. What's in the yellow box here is really important, I think, for practice and for the boards. You need magnesium to be able to hold on to potassium. And I've seen lots of cases where someone's hypokalemic and they keep giving them potassium and giving them potassium and giving them potassium. They just can't get it to bump up, or it bumps up and it goes back down again. It's because they are hypomag. So you got to have magnesium on board to hold on to your potassium. So frankly, I don't even check the magnesium levels. I just give it empirically. As long as the person's got functioning kidneys, a couple of grams isn't going to hurt them, okay? And it's cheap, right? Magnesium. How expensive can it be? No drug companies are pushing magnesium. So I figure a couple of grams IV is going to help you. So if someone's hypokalemic, enough that you're repleting them, not just like one dose of PO or something, and you got a line in them, just go ahead and give them some IV mag as well. A couple of grams will help. So fix the mag. Okay. Hyperkalemia. You know this is going to show up on the boards. There's no way this cannot show up on the boards. It's a classic emergency for us, so we know about it. Okay, what causes hyperkalemia? Of course, it could be a lab error, hemolysis, things like that. Lots of blood. Bless you. Increased intake. That's pretty rare. Pile of bananas. Pen VK, penicillin VK. The K is potassium. Maybe take a bunch of that. I don't know. But decreased output? Sure, absolutely. Renal failure. We know we see that all the time. Anything that causes an acidosis will give you hyperkalemia. You have an acidosis, you want to hide your hydrogen ion now, so you put the hydrogen ion in the tissue, pull the potassium out of the tissue. Okay? That's why patients who've been in cardiac arrest and they've been down with a bad acidosis, they're almost always hyperkalemic. It's not necessarily that it was a hyperkalemic arrest, but the person was down long enough, they got acidotic, and now they're shifting the potassium into their blood. Okay? Still fix it. It's still potassium in the blood, but that's one of the things you'll see. Other ways to get it: crush injuries, right? From tissue, crush injuries will do it. Digoxin toxicity, where dig poisons that sodium potassium ATPase. Succinylcholine absolutely can do it, right? You know about that. You remember if you take a normal person, let's say their serum potassium is 4, you intubate them with a dose of succinylcholine, their serum potassium would now be maybe 4.5, maybe 5 at the most, but probably 4.5, okay? It's going to go up a little bit, normal person. Because succinylcholine makes your muscles twitch, right? Depolarizes, and it leaks out a little potassium. But you take a person who has denervated muscles or has, other, muscular problems like an old burn or old stroke, more than 72 hours, things like that, right? Instead of those little acetylcholine receptors just hanging out at the neuromuscular junction, they're hypersensitive and they're spreading out all over the place. Now you give that person a dose of succinylcholine. Instead of going from 4 to 4.5, their potassium, it's going from 4 to 6 or 4 to 7 or 4 to 8, and they widen out and they arrest right in front of you, okay? So you definitely got to be careful for the contraindications of sucks, and if you're at all worried, just use a non-depolarizing neuromuscular blocker, right? So like rocuronium or something like that. Okay. Signs and symptoms. If you think about it, you don't get a lot of symptoms with hyperkalemia, right? I mean, people aren't complaining of much when they come into the ED. The chief complaint's usually either, I missed dialysis, right? Or I was in clinic and they said my potassium was high, so they're sending me over to you to fix it, right? So you don't get a lot of symptoms from hyperkalemia, but you do get the cardiac manifestations. Again, you all know this. Quick review. First thing you get is peak T waves as it goes up. And remember, peak T waves are not just tall, but they're pointy, they're sharp, they look like they're going to hurt when you put your finger on the top of it. So you get peak T waves. You then start to widen out your PR interval. So now your intervals start to widen. Your PR interval widens. Your QRS starts to widen. That widens all the way into a bundle branch block. Then that degenerates into a sine wave, very pretty sine wave. And then everyone's last rhythm, asystole, okay? So peak T waves, long PR, long QRS, bundle branch block, sine wave, asystole. And obviously the higher the potassium, the more you are along that pathway. Treating hyperkalemia, again, you do this all the time, just a few points. The thing that's going to work the fastest is calcium, right? So calcium gluconate, give them an amp of calcium IV. That's going to help. All it does is stabilize the cardiac membranes. Doesn't get rid of the potassium, doesn't hide the potassium. It's just a temporizing agent. It's going to last, what, 10, 15, 20 minutes, something like that. It's temporizing. That's all you're going to get out of it. Stabilizing things. That's the calcium. Then you have things where you can try to shift the potassium into cells to hide it. Things like insulin, right, with some sugars, some D50 as well. Bicarb can shift it into cells. Beta agonists can shift it into cells, right, albuterol, nebs, things like that. All those things will hide the potassium, which is good for your heart, but it's still in your body, gets rid of it. Diuretics, if they're still making urine, that helps, because that'll actually take the potassium out of your body. Dialysis, of course, is a great way to get potassium out of your body. So that works very, very well for patients who, have end-stage renal disease. That works great. And then what about K-exolate? Let's just talk about this for a second. K-exolate. You remember K-exolate. We used to use it all the time. We're using it pretty infrequently now, okay? K-exolate, if you remember, you could take orally or rectally, and it was kind of like, it was like colonic dialysis in a way, right? It like bound to the potassium, and it kind of pulled it out of your system was the idea. Well, here's the problems with K-exolate. The first thing is that a single dose doesn't do almost anything, okay? It does almost nothing to your serum potassium level. So if you're going to use K-exolate, you would need multiple doses of it, okay? And the problem with it is that, particularly when you give it with sorbitol and in multiple doses, you can get intestinal necrosis. So it's been associated with intestinal necrosis. So that's not good, to necrose your intestines, bad stuff. So because it doesn't work real well, and you got to give a bunch of it, and it can cause intestinal necrosis, and we have other agents, it's probably not the best thing to be using anymore for hyperkalemia, okay? Particularly in somebody who has slow GI motility. So I would definitely not use it post-op, ileus, bowel obstruction, patients on opiates, anything with slowed gut motility, definitely avoid the K-exolate. Is there any time that I might use it? Okay, yeah, sure, I can imagine a scenario, severe hyperkalemia, not getting better with all the other treatments. Might I add some? Sure. Or severe hyperkalemia, that's going to be a bad, long delayed dialysis, and it's not going down as much as I want. Might I try to temporize with it? Okay, maybe, all right? But for the most part, not using it like we used to, which was basically everybody who had hyperkalemia used to get it. There's this other thing I hear about not using calcium in hyperkalemia when the hyperkalemia is from digitoxicity, and this is important. When someone has digitoxicity, you know they can get hyperkalemic, but we're supposed to not use calcium because it can cause this bad conduction thing called stone heart, all right? Don't even have to know what it is. It's not good, right? You don't want stone heart. I will tell you, it is controversial in the literature. Some toxicologists think it's real. Some toxicologists think it's not a big issue. But at the end of the day, it doesn't matter because what these patients really need is the digibind. So the calcium is kind of a moot point anyway. So when somebody comes in to your ED and they're digitoxic and they're hyperkalemic, I'm probably not going to be reaching for the calcium. I'm going to be reaching for the digibind as quickly as possible. And if they ask you that on the boards, the answer would be no calcium, okay, if they have digitoxicity. Again, it's controversial, but if they ask you it on the boards, that they want to know you know that. Okay, so we did sodium, we did potassium. Pretty simple. Let's cruise on here. Calcium. There are three big players that have to do with calcium: the parathyroid, the vitamin D, and the kidneys. Parathyroid hormone's job is to raise calcium. So when you have more parathyroid hormone, calcium goes up, and by the way, phosphate goes down. They go in opposite directions. So parathyroid hormone brings your calcium up. Vitamin D, it's made by the kidney. If you remember, it's activated by sunlight. That's why you need to get some sunshine or drink your vitamin D enhanced milk. You need vitamin D to absorb calcium from the gut. If you don't have vitamin D, you can't absorb it from your food. You need it. And then the kidneys play a dual role. They make the vitamin D, and they also absorb calcium from the urine, right? They keep you from peeing it all out. So the three big players: parathyroid hormone from the parathyroid gland, which will bring your calcium up; vitamin D, which you need to keep it from your gut; and the kidneys, which you need to make the vitamin D and to keep it from your urine. Those are the three big players in calcium, and usually when there's a problem, it's a problem with one of the big three. This is a mnemonic. Again, I'm not a huge mnemonic fan. This is Pam P. Schmidt. I don't think you probably need to know every single one of these for the EM boards, but this is a bunch of causes of hypercalcemia. Some of these are clearly fair game. The first one is, right, hyperparathyroidism. Yeah, that's the fair game one for sure. Addison's, not so much. Multiple myeloma, yeah, a lot of bone turnover, so hypercalcemic. Paget's, bone turnover. Sarcoidosis, turns out a lot of these granulomatous disease make a precursor of vitamin D, so you can get hypercalcemic from that. Cancer, you got to know that one, could be from bony destruction. It could be because the cancer is making a PTH-like substance, okay? That can happen too. Hyperthyroidism, it's one of the hypers. It's one of the things where all the things go up in hyperthyroidism, the calcium going up, increased bone turnover, that's why. Milk alkali, that's a little internal medicine-y, probably not going to be on our boards. This is somebody classically who's taking a bunch of supplements, vitamin supplements and antacids together. When they hyperabsorb and they get an alkalosis and they get hypercalcemic as well. But we don't see that too much, at least I don't diagnose it too much. Maybe I saw it but didn't make the diagnosis. I don't know. Immobilization, sure. Bone turnover with calcium. Vitamin D intoxication. Yep, that's one of the big three. So too much of that would cause high calcium. And then thiazide diuretics, I don't know why, but it seems like it's been on every exam I've taken since like a first-year medical student or something like that. So who knows? It could show up as well. Thiazide diuretics cause hypercalcemia. It's just a factoid. Remember what these patients look like? They look like sick, altered diabetics. That's what they look like. They're dry, they're altered, they're feeling awful. They look really sick. So what they get is stones, bones, moans, and groans. All right, let's kind of go through it. So neurologic, they get altered and weak. So they're altered and they're weak from this hypercalcemia. EKG, high calcium, short QT. Low calcium, long QT, okay? Bless you. So in hypercalcemia, you're going to get a short QT on your EKG. That would be a great exam question for the boards, right? They show you the EKG, and the only thing wrong with it is a short QT, and they give you a little history, it's hypercalcemic. Renal, they get polyuria, polydipsia. They look like a diabetic patient. They actually have a nephrogenic diabetes insipidus. That's why. They're peeing out like that because their kidneys don't respond to ADH. So they're altered and weak, short QT, they're peeing like crazy, they're uncomfortable, they got belly pain, they got nausea, they got bone pain. They're just like really unhappy, uncomfortable. That's hypercalcemia. Treating hypercalcemia, we used to say, give them a bunch of normal saline and give them a bunch of diuretics. But it turns out patients got volume overloaded and electrolyte imbalance. So now what we just say is give them normal saline. So get them up to euvolemic and then give them enough normal saline just to keep them peeing it out, and they'll eventually pee out their calcium. So normal saline is the most important answer that we're going to do down in the ED for hypocalcemia, is giving them normal saline. Now, would you ever give them diuretics? Sure, if it's not correcting at all, or if the person is like heart failure or renal failure, you're not just going to give them a bunch of fluids, you'll give them fluids and diuretics. But other than that, it's just give them the fluids, don't give them a bunch of diuretics. Then there are these other agents that you can use, calcitonin and the biphosphonates. These are things like, zoledronic acid, pamidronate, etidronate, things like that, okay? If you remember, what they do is they inhibit those osteoclasts, the things that chew up your bones and release the calcium. So they will bring your calcium levels down. It turns out that calcitonin, that's a pretty good onset, but it'll only last for 2 days. After that, it doesn't work. Your body gets used to it. It doesn't work. Only work for 2 days. Biphosphonates, those things take about 2 to 4 days to start working. So it's like perfect. You got the calcitonin, which is giving you the first 2 days worth, and then you got the biphosphonates, which are taking over once your body can't deal with the calcitonin anymore, okay? And those are mostly upstairs medicines, not downstairs medicines, but just in case they show up on the exam. So you start with some normal saline and maybe some calcitonin and biphosphonates is the other thing. That's how you treat high calcium. Low calcium causes, you mess with one of the big three, hypoparathyroid, right? They're taking out your thyroid, and they accidentally took out your parathyroid glands too. So you mess with one of the big three. Hypoparathyroid, renal failure because the kidneys now aren't working, vitamin D deficiency, one of the big three. Pancreatitis, remember Ranson's criteria? Patients with bad pancreatitis, they actually precipitate out their calcium. So they get a low calcium because it's so severe. Don't worry about the drugs. You're not going to memorize it. There's too many. Forget it. Give it up. DeGeorge syndrome. These are kids born without a parathyroid gland, okay? So this is congenital hypoparathyroidism, what that is, okay? So they can also get it. It's, again, one of the big three, kids with no parathyroid. So if you just remember the parathyroid, the kidneys, and vitamin D, that's really going to be mostly it. Signs and treatment of hypocalcemia. Remember, your nerves start getting really irritable. Your nerves and muscles, like everything's just like really irritable with this low calcium. So everything's twitchy and jerky. You get paresthesias. And then you get twitchy and jerky stuff, right? Hyperreflexia. And remember Trostex and Trousseau's signs. Which one's Trostex? Show me Phosphate. That's right. The one here at the cheek, right? So remember your facial nerve here. I mean, normally you tap on it, nothing happens, just tapping. But it's so irritable that you tap on that facial nerve and it starts to spasm. You contract, or activate, I should say, and you get the spasm sort of thing, right? So you tap on it and you get motor activation of the face, that sort of thing. That's Phosphate sign. Trousseau's sign is you put a blood pressure cuff on the person, put it up for a couple minutes, and they start doing this thing, right, on the arm. They start getting, like when you hyperventilate, they get that carpal spasm. They do this. That's Trousseau's sign. And I just remember it, Phosphate cheek, C-H-C-H. Phosphate cheek, and Trousseau's, well, that's the other one. All right, sorry. Can't help you there. Okay, treating hypocalcemia is really simple. Give them calcium, okay? You can give them calcium gluconate, that sort of thing. Get their calcium up. One slide for magnesium. Let's do it real quick. We can do this one easy. For magnesium, how do you get high mag? You either have renal failure and you can't pee it out, or somebody puts you on a magnesium drip because you have eclampsia or preeclampsia or something like that, okay? That's probably how you're going to get it. You don't see high mag that often, except for your dialysis patients. So they can't pee it out or you gave them too much. That's hypermag. What's the first sign that you get with hypermag? How did the OBs know that they got too much mag, their patients? What did they do? Hyporeflexia, right. So they're checking the reflexes in their patients. They're going around checking them. So the first thing that happens is you get hyporeflexic, and then you basically get weak, and then you can get respiratory depression. That's just like diaphragm weak. Think of it that way, all right? The antidote for magnesium is calcium. So when they're hypermag, you give them IV calcium. And of course, you can do dialysis as well, particularly if they're a dialysis patient, get the magnesium off, okay? So calcium is the way you treat high mag. You don't see it that often. Hypomag, you see all the time, probably every single shift in your emergency department, you're seeing multiple patients with hypomag. Alcoholics, patients that are malnourished, patients on diuretics, DKA patients, and frankly, they've done studies of just ICU patients, and like a third or half of them, serious numbers of them are hypomag. So lots of patients get hypomag. The symptoms are pretty much like hypocalcemia, that twitchy, jerky sort of stuff, because magnesium and calcium look like each other, right? So low mag is very much like low calcium, and you treat it by giving a mag, okay? Just give them some IV magnesium, and that fixes them. Simple. So that's it for magnesium. Let's do phosphate real quick. I mean, phosphate, seriously, for an EM board exam, that's kind of painful, right? That's cruel. It's kind of cruel. So we'll go through it quick. Here's the way I think about phosphate metabolism. You eat it, you absorb it, you pee it out, okay? That's phosphate metabolism. Real simple. Remember, parathyroid hormone makes calcium go up. It makes phosphate go down. So they're always going in the opposite direction if it's under parathyroid hormone control, okay? If all is normal, or at least right with the balance, they're going in opposite directions. How do you get a high phosphate? You either have a low parathyroid, right? So low calcium and high phosphate. You have renal failure where you can't pee it out, or you have secondary low parathyroid, right? So it's the parathyroid's reacting to something else. But basically, it's either a low parathyroid or renal failure where you got too much phosphate on board. Those are the ones that are going to show up that make sense, okay? The symptoms from the high phosphate, it's actually usually the low calcium that gives you the symptoms. And how do you treat it? You use these binding gels to get rid of the phosphate, right? These oral binding gels, these are like those Renagels and phosphogels, those sort of things that you can take to try to bind up the phosphate and get rid of it. And you can do dialysis, of course, to get rid of phosphate too. How about a low phosphate? How do you get a low phosphate? Well, either decrease intake, like malnutrition, NPO, things like that. Increase output of your phosphate, diuretics, DKA, things like that, diarrhea. You can lose some phosphate. Signs of hypophosphate. Remember, you need phosphate to make ATP, ATP for energy. So the biggest thing with low phosphate is you're weak, okay? So you get weakness. The other thing is it turns out you need phosphate to stabilize cell membranes. So you get lysis of things. So you get hemolysis and you get rhabdo. You get rhabdomyolysis because the cell membranes are unstable. So you're weak, and then you get like a hemolytic anemia and rhabdomyolysis because your cell membranes are weak because they don't have enough phosphate, all right? That's low phosphate. And treating phosphate is you give them phosphate. Oral if it's mild, IV if it's severe. Pretty simple. Okay? So we've done all the hormones. We've done all the electrolytes. We just have a little bit of acid base, some simple little bit of acid base, and we're done with endocrine, all right? We're almost there. So let's start with our friend, the anion gap. You know, obviously, important stuff to know how to calculate an anion gap. What is the anion gap? Think of it this way. In your blood, you got positively charged stuff, right? Some cations. You got a bunch of negatively charged stuff, some anions. And there's a zillion of these things, and they're all floating around in your blood. And, you know, everything's like yin and yang, nicely balanced. Your blood's all happy, right? And if you were to send off a lab panel called a chem-1,000,000 instead of a chem-7, you wouldn't have an anion gap because you'd be measuring everything, all right? Yin and yang in balance. But the problem is we don't send off chem-1,000,000s, we send off chem-7s. And when we send off chem-7s, we're only measuring a little bit of positive stuff and a little bit of negative stuff that's down in the formula there, right at the bottom. So we're measuring the sodium and the chloride and the bicarb. And the way you calculate your anion gap is you take the sodium, the positive thing, and you subtract the sum of the negative things, the chloride and the bicarb. And that gives you a gap. And the reason there's a gap is because there's more sodium than there is those other things, and we haven't taken into account all the other things that are outside in the blood. Just these three things, there's going to be a gap. And the normal gap is like what, less than 12, less than 14, depends on your lab. But that's why we have a gap to begin with. Now, before I tell you about all the things that cause an elevated anion gap, and you remember mud piles, you know it's coming, right? Let me just tell you a minute about some things that could cause a decreased anion gap. We don't think about that or see that often. What could cause a decreased anion gap? How would that happen? So it turns out that if you pee out a bunch of negative things like albumin, right? Albumin is a negatively charged protein. If you lose a bunch of negative things like albumin, or if you have a bunch of extra positive things like in multiple myeloma, you got positively charged proteins sticking around in your blood, right? If you got a bunch of extra positive things or you've lost a bunch of negative things, your body wants to compensate for that. And the way it compensates for that is it holds on to bicarb. So I lost negatively charged albumin, no problem, I'll hold on to bicarb. I got a bunch of positively charged multiple myeloma, no problem, I'll hold on to bicarb. It holds on to bicarb. Okay, and what happens when you hold on to bicarb? Let's look at our formula. What happens when bicarb goes up in this formula to your anion gap? It narrows, right? That's what's going to happen because your sodium's here, your bicarb was here, but it went up. Now your gap is narrower, okay? Does that make sense? So anything that's causing your bicarb to narrow, or to raise, I should say, will narrow your anion gap, all right? So that's one thing I wanted to point, is that there are some states like hypoalbuminemia or multiple myeloma, things like that, can cause a narrow anion gap. There's one other thing I really want you to know about that can cause a narrow anion gap, and it's bromide intoxication. Remember, bromide is Br negative. Chloride is Cl negative. If someone's got bromide intoxication and you send their blood to the lab, the machine thinks bromide is chloride. It doesn't know any better. So it's going to report it out as chloride. So all the bromide molecules just gets reported out into the chloride number. So the chloride number is going to be really, really high. Now again, looking back at our formula, what happens if the chloride number is really, really high? Well, your anion gap is going to narrow, right? Because your positives aren't bigger than your negatives anymore. Like they're getting narrower and narrower. In fact, with bromide intoxication, you can have a negative anion gap, and that's kind of a pearl for you, all right? If you ever see a negative anion gap, that chloride is so high that it's even more than the sodium. Negative anion gap, it's not really chloride, it's probably bromide, Br negative, and the machine's just reporting it out right, all right? So bromide intoxication, negative anion gap. Okay, now we got to move to all the things that cause an elevated anion gap. Again, you think about this every day in the emergency department when you see somebody with a metabolic acidosis. They've got a metabolic acidosis. First thing you do is calculate, is it an elevated gap or a not elevated gap? And that'll tell you your differential. So elevated gap, metabolic acidosis, is mud piles. You've seen it a million times. M for methanol, U uremia, D for DKA, but I also throw in alcoholic ketoacidosis, starvation ketosis, any ketoacidosis is in there, right? P for paraldehyde or fenformin. Fenformin is actually off the market, replaced by, remember, metformin, right? Metformin can cause lactic acidosis. They took fenformin off because it was causing too much lactic acidosis. But paraldehyde, metformin, those things can do it. I for iron or INH, L for lactic acidosis of any cause, E ethylene glycol, and S for salicylates, right? Your aspirin overdose, salicylate overdose, those sort of things. The answer is almost always somewhere there on mud piles when someone's got an elevated anion gap acidosis. So this is one mnemonic that I do remember, and I encourage you to remember it too. Lactic acidosis is the L in mud piles, right? Elevated gap acidosis. There are three types of lactic acidosis. I'll make it real simple. One type is the type like if I go to run up to my room right now, I'm going to get a lactic acidosis. It's just hypoperfusion, okay? I'm not in that great a shape. I run up to my room, that's one type. The second type is from medical conditions. You know, seizures, liver failure, things like that, right? Medical conditions causing a lactic sepsis, causing a lactic acidosis. And then the third type is medication related. And there's a huge list of medications that can cause lactic acidosis. You'll never remember the whole list, but there are a few you should remember and that I think are testable. Toxic alcohols, that should be on your list. Metformin, that should be on your list. And some of the antiretrovirals for treating HIV, those should be on your list. So they get a lactic acidosis on a test question, and they're talking about different medicines that may or may not be associated with it. Toxic alcohols, metformin, antiretrovirals would be really kind of common and testable ones, I should say, that could show up on the exam. So I would know those. But there's a long list. Okay, how do we get a non-GAP acidosis? Let's think about this for a second. You have an acidosis because you've lost bicarb, right? You lost bicarb, you got an acidosis. But for a non-GAP, you're losing bicarb and you're losing sodium. So you're losing the negatively charged thing in the formula, but you're also losing the positively charged thing in the formula. And if you're losing them together, you don't get a gap, right? Your gap stays the same. If it was 12 before, you lost them both, it stays 12. So these are disorders where you lose both sodium and bicarbonate at the same time. And there's a mnemonic here to help you remember. If you like this one, hard up, places to look. I just remember this as renal and GI. Almost all of the causes of a non-GAP acidosis are going to be renal or GI somehow, okay? So let's just go through the list to show you what I mean. Hypoaldosteronism, so that's coming from the adrenals, okay? It's right next to the renals, all right? So you gotta give me a little room there, all right? The adrenals. Acetazolamide, that's a diuretic, that's renal. Renal tubular acidosis. Diarrhea, that's GI, right? Pancreatic fistula, pancreas, that's part of the GI tract. And then ureterosigmoidostomy. They took a renal and a GI and they stuck them together, okay? So it's both renal and GI. So next time you get a non-GAP acidosis, just look down the answers and say, is it renal or GI? And those are going to be the ones. Okay, so those were your metabolic acidosis. How do you get an alkalosis, a metabolic alkalosis? Well, you either are holding on to too much bicarb or you got rid of hydrogen ion somewhere. Where do you lose hydrogen ion? Gastric acid, right? Vomiting, NG suction, diuresis, where you're just peeing it out. And how do you hold on to bicarb? Well, anything that gives you alkalosis can do it, right? Citrate, lactate from transfusions, it gets converted to bicarb. Antacids, you know, lots of things can do it. Dehydration. Okay, some people talk about this chloride sensitive versus chloride insensitive metabolic alkalosis. Chloride sensitive just means that the person's dry, and chloride insensitive means that they're not dry. So chloride insensitive are the weird things like mineralocorticoid excess. Chloride sensitive are the usual things. Like they got vomiting, they got diuretics, that sort of thing. So I don't think this is probably going to show up on the EM boards, but I wanted to mention it to you just in case. If anyone talks about chloride sensitive alkalosis, it just means it responds to fluid, okay? They're dry. That's it. Pretty simple. Okay, the last thing I want to cover with you in endocrine is osmolality. Okay, just like you got positive and negatively charged things floating around in your blood, you got a bunch of solutes floating around in your blood, a bunch of molecules floating all around in your blood, and they each have little molecular weights, right? You got some BUN, you got some glucose, you got some sodium, you got all these different things that are floating around in your blood, and they all have different molecular weights. And if you were to take a blood test and add up all that solute, those would be your osms. That's when you take blood to the lab and you say, what are their osms? It's measuring all that stuff floating around in the blood. Those are the osms. And normal osms, you know, 280, 295, something like that. That's your normal serum osms. You can measure it. You can also calculate the osms if you want to try to get an estimation. And the way you calculate the osms is the formula down at the bottom of the slide here. And you basically take twice, it's kind of a little covered up here, but it's twice the sodium plus the glucose over 18, which is its molecular weight, by the way, plus the BUN divided by 2.8, which is its molecular weight, okay? And if the person also happens to have alcohol intoxication, they've got alcohol on board, you could also account for the alcohol by measuring it and using alcohol, ethanol over 4.6, okay? But basically, you're gonna calculate it up to get an estimate. So why would we ever care about this for the EM board exam? The one scenario I can think of is when you have what's called an osmolality gap. So say, for example, you get someone's blood, you do the calculation, and their osms come out at 280. And you say, okay, that's normal, it came out at 280. But you send the blood to the lab, and it comes out at 310. What's going on there? That means there's something in the blood that the lab is picking up that was not in your equation, okay? It wasn't in your equation. And when you see an osmolality gap, that is a difference more than 10 between the measured number and your calculated number, I would go directly to toxic alcohols. That's probably what's going on, okay? One of the toxic alcohols. So on the board exam, if they ever give you chemistries and the osms, they say, oh, the osms are 310 or something like that, they want you to go ahead and calculate the osms and compare what you calculated with what they measured and see if there's a gap. And if there is a gap, elevated gap, more than 10, think about toxic alcohols, okay? The last thing I'm going to tell you, my last kind of weird trick, again, I had a hard time remembering what the number was for ethanol to put beneath it. I always learned the glucose over 18 and the BUN over 2.8, and that always stuck in my head for some reason, I don't know why. But I could never remember the ethanol. And this is the final trick that I learned to remember what you put under ethanol. You see the let me see if I can do this here. So glucose is over 18, BUN's over 2.8, right? What if I put a dot between the 1 and the 8 for the glucose and turn that into 1.8? 1.8 plus 2.8 equals 4.6, all right? So I know it's crazy. That's it. Have a nice lunch.